That helps out.
Thanks, Alan. Okay, so I'm not even sure I can remember how to call this meeting to order.
Say I call this meeting to order.
Okay, I call this meeting to order. Nick, we have a quorum?
Yes, Madam Chair, we do have that quorum.
Okay, let's, Ted, will you lead us in the pledge?
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay, and then, Nathan, do you mind praying for us?
Okay. Father, please bless what we're doing. Please give our minds lots of wisdom. Please give us all grace and kindness and forgiveness. In Jesus' name, amen.
Okay, so now I think we're ready for Allison.
Great. Give me just a second and I will get my slides.
You want me to?
going.
They're
I think-
public meetings, so we'll better leave them open.
I think we need to leave it open.
Yeah, you should. Can you see that okay? So this is my attempt at humor. This is for those of you who've been on the board, you when you first started your job. And for those of you who've been on the board for a little while, maybe what you're feeling like, right? And
Pretty
you're
well.
thinking, yeah, and you're thinking, well, I'm just a volunteer, but here we go, okay? So we've talked about this, and I'm sure a lot of you have heard this before, but we started a high level at the fiduciary duties of board members. And so, sorry, and so it starts with caring, that you're loyal, that you're obedient. And so what does that look like? Well, the duty of care is what a reasonable and prudent person would do. So you need to make informed decisions and you need to ask questions if something doesn't make sense or you don't understand. You have a duty of loyalty, which means you need to act in good faith without self-interest and not disclose confidential information. A duty of obedience means you comply with all laws, rules, and regulations and encourage everyone else to do the same. And finally, you have a duty to ensure quality, which is a board duty that is very specific to hospitals. So you're responsible to ensure that the medical staff and hospital employees are providing patients with safe and quality care. And that's a high-level overview of all of this compliance work falls under all these fiduciary duties, like caring, being loyal, making sure we're following the laws, and then also ensuring quality.
Allison, can I ask a question
Sure.
before we move on?
Yeah.
So what's the source for this? Where do these duties come from? Is this like the IRS or state law or?
Yeah, so it comes from, it's based in common law, which common law means like the Old English Code. And the states have adopted it not so much through statute, although there are some, such as loyalty and obedience, right? But the other
Right.
pieces of it have been created through case law.
Okay. And
And
so,
it's adopted in Wyoming. And then at the
okay.
quality level really comes from federal rules and compliance.
So for loyalty, we all were elected by our community to act in good faith and do what's good for everybody.
Yep, for the best interest of the hospital. And when you think about what that is, you can have viewpoints that conflict on what you think might be best for the hospital versus someone else. And that's the idea of having a board, is that collectively you'll come to the right decision.
So we have a duty of loyalty to the hospital.
Yes, to the institution that you represent.
Okay.
Yep. And so sometimes that aligns with the public. Sometimes the interests of the public, for example, a physician who competes with you may want something to happen, right? But it's not technically good for the facility. That would be an example of your duty of loyalty would be to the hospital organization first when you're acting as a hospital board member.
Thank you.
Yeah, you bet. So I had Denise, hopefully she had emailed out and maybe made a couple copies of the OIG report on what a compliance program looks like, what the components are. So if any of you want to nerd out, you can feel free to read through the whole thing. As I said, at about page 43, there's information about a board's role as to compliance. So at a high level, it's to ensure that your organization has a compliance program, that it meets the basic requirements under federal law, and that it's functioning. Beyond that, you need to ask the right questions of management to make sure that it's functioning, to help identify if there are any major flaws in the compliance program, things that are being overlooked. And then you need to make sure that there is an ongoing audit system in place for your compliance program, the compliance program itself, and then all of the legal requirements that we'll talk about.
So
You need to
Allison,
know-
can I ask a quick
Sure.
question?
Yeah.
So I'm brand new to the whole HIPAA compliance and all the other compliances we have to do. How can I, as a board member, understand if our program is functioning? You said we're responsible to make sure it's functioning.
Yep. And so
How
the
could I know?
organization, yep. So the organization needs to provide you with education so that you can know. And for those of you who take a keen interest in the compliance piece, and it would be wise if one or two of you decided to pursue further education in this, there are conferences for hospital boards throughout the nation, like the American Health Law Association. There's hospital board associations. They put on programs educating boards about these laws and compliance, and we'll go over it at a high level so that you'll at least have some basic understanding. But ultimately, as a board, you should have a basic level of understanding of these laws so that you can ask questions and understand whether you feel comfortable with the compliance that's being undertaken. Does that help?
It does. Thank you.
Yeah, and I can't see you guys, so you'll just have to, you're very small, so just shout out.
Kim
Go
was
ahead.
wanting something.
Yeah.
So one thing that I kind of worked with Darren with is we're gonna start a compliance committee. And then I will bring information from that committee and present it to you guys as a board. So that's how you guys will also get your compliance information about the
So
ordinance.
it would be like your quality committee and like the finance committee, so people
Yeah.
on the board will be on.
So I asked Darren, I said, do you recommend people on the board being on there? And he was a little about that part.
Okay.
But you know, that's something that I can revisit if you guys would be interested in that. But basically quarterly, I would be coming to you guys with an overview report of here's the compliance. Here's issues that we have found that could be a foreseen issue that we're handling and
So he was recommending that the committee be hospital staff?
yes.
Okay.
Yes, like the directors and managers, people that would be hands-on in their department's compliance.
So just as, so I have a kind of a point of reference. So we're talking about a broad umbrella called compliance. Can you give me, so we've talked about HIPAA some already, but are there other sort of categories that we're discussing?
Yep.
Okay.
Yep, there's a whole lot. And so my presentation's probably going to take about 45 minutes. And then from there, if you want to, and feel free to interrupt, I don't mean to stop you, but I'll go through at a high level the main areas that you need to be familiar with. That OIG resource has a lot of information in it. It may be overkill. Again, other boards that I work with send board members, one or two, to these educational trainings. I highly recommend it. I also think it's something that would be very beneficial for Kim. And I'll tell you, I think that Kim has done a really nice job with the resources that she's been given, but I do think that there are steps that should be taken to make this compliance program more robust, and the recommendations Darren have made, you'll see as themes throughout this presentation. And so again, the compliance program is designed to prevent, detect, and correct problems. So like we should be auditing, we should identify issues of concern. The reason it's usually not the board members on the compliance committee is you really need people who are in the inner workings of the facility. You know, maybe it's somebody in billing, somebody in the compliance group, some staff. It's kind of a mix. And then we need to make sure that our program values and rewards prevention, detection, and correction. Some facilities work to try and achieve really great numbers, but they suppress people from reporting any compliance problems. And that really is just building up to have a mess in the long run. And then we need to assess our programs and find the areas that we're weak and then update them regularly. So what is contained in a hospital compliance program? Well, we have a compliance officer, which is Kim, and then we may have other staff, and we need to make sure that we have a mission and sufficient resources for the work that they're doing. Usually it ties back to the hospital's mission statement, but you could have something additional. Again, the compliance committee, which helps evaluate and carry out the compliance program itself. Something you may not have that is recommended is a risk assessment tool, and they exist out there. You know, OIG probably has some available. If not, my friends at Campbell County could probably tell you what they've used, Kim. But
Darren shared one with me, actually.
oh, great. So that's a great starting place to say, okay, what are the things that we have going on? You know, what are areas of concern now? And then as time goes on, you can reevaluate because things change all the time. You need to make sure that you have a hotline that's available and publicized for employees, contractors, and patients if they have compliance concerns. And I didn't know if you had one, Kim.
We do, yes. And I do post it around the hospital, but I do notice that it gets taken down a lot, so then I have to go repost it. So I struggle with that part.
Yeah, and that gets back to training and education for our team, right? To make sure they understand how important that is, that that's available. That's a part of your license to operate, is making sure you're compliant and that that information's available. And then if there are investigations, making sure that, you know, the results and findings are shared with the board and departments so that there can be learning and growth. If there are audits and there's findings from them, we need to make sure that we are tailoring our trainings that we have for our people toward those issues. For example, one of my clients had issues with billing, which I'll get into more detail about later. And so they did training specific to the billing issues that they were having so that all of the staff understood what the issue was, what the danger of billing inappropriately is, and how to identify and stop having the problem. And then, are we auditing the systems, processes, and people? I know you're a small organization and, you know, small staff, but based on that risk assessment tool, we ought to find out what our weak spots are and start auditing them and making sure that we're making improvements. So, Kim,
How
anything
often-
you want to add?
Yeah, how often would you suggest doing those audits?
So it depends. It's different for each of the areas, and we'll talk a little more during the HIPAA part, but like our HIPAA access should be audited on an ongoing basis. And I think Kim's working on getting the resources in place to be able to do that ongoing. Other audit areas should be audited when you either think that there's a concern, or you should make a list of maybe the 2 or 3 high priority areas that you that the OIG has identified as high risk for your type of hospital and just rotate them through. Maybe it's annual, maybe it's twice a year, one 6 months, another 6 months. But you should have an auditing program and put resources toward that. So
Thanks.
Kim, do you want to add anything on that?
So when I had talked to Darren, his recommendation was to have the managers, I was gonna share that risk management tool with the managers. His recommendation was that they identify 2 risks and then fill that out and then bring it to every compliance meeting beforehand so that we can discuss them. And so he said do that monthly and then quarterly until it gets kind of set in stone, and then we can adjust it from there, so. He
The
said
other
it's-
really good thing about that is that it helps your people know that you're listening. So if they identify a risk and an issue, that you can start to work on it. So then we talk about the compliance officer and specialist. So Kim's in that role, and I don't have the org chart. I think there may be an issue with this. Currently, she reports to the CEO. She should also have a line directly to the board. She is developing, implementing, and managing the compliance program, addressing any of these billing, reimbursement, and HIPAA compliance issues. And she's also responsible for properly reporting the violations. What the OIG manual suggests, and I think is a good idea, is to have a standing time where you get a report from Kim in executive session. Maybe it's quarterly. It's up to you how often you'd like to have it, so that she has a place to go and talk to the board about any compliance concerns that she's identified, and if there are any major issues that they can be reported to the board. Because the board does have a duty to know.
So Allison, just, so on that, what's the proper, like, if Kim was reporting to us about compliance stuff, is it proper for Kim to be the only one in the room with us, or should the CEO also? Kind of what's normal?
So if it involves the CEO, then the CEO should not be present. If it does not involve the CEO, then it's fine to have the CEO present.
Okay. Okay, thank you.
It's the reason that the compliance officer needs a direct line to the board is so that if there are issues that the CEO is not dealing with, that the compliance officer has concerns about, that they can go directly to the governing body, which is the board.
Thank you.
Yep. So then the facilities that have compliance committee, it also usually includes HIPAA related issues. So they're looking at whether there are policies and procedures in place that carry out the compliance requirements. They complete any investigations of privacy, compliance, and security breaches. They update and create any policies and procedures related to all these issues. They report out to the quality committee if that's the appropriate place, and maybe Darren had other advice, and then the board of trustees. And then additionally, they should be furthering education for the organization from the board down through the entire organization on compliance, privacy, and security issues. And one of the things we see an overlap in is your IT system also ties into your compliance, and especially your HIPAA issues, which we'll talk about a little more. And so at some point it may make sense for Wendy to work with Kim, and maybe she's a person that would make sense to be on this committee, depending on what you all decide. So anything you want to add, Kim?
No.
Okay. So then we talked briefly about the risk assessment tool to help you identify compliance concerns. You should do that at least annually, and then it should be updated based on the identified risks. So for one organization that I worked with, they noted that a lot of the risks that they had weren't actually that they had a compliance risk, but it was more that the employees in the organization didn't even know they had some of this stuff. So a lot of what comes out of the initial rounds of these risk assessment tools, I find, is areas that the staff need to be further educated on compliance. So on your hotline, what happens is it's important to have that communication be able to be reported anonymously. So it could be through a phone line, it could be through email, through paper form, or direct communication. Like sometimes I've seen individuals go in while I'm at a facility and actually report it to the compliance officer while I was there. So if there is a report of an issue, then there needs to be an investigation where the facts are gathered, interviews are conducted, reviewing policies and procedures, potentially statutes, sometimes calling legal counsel. Then you need to provide a written report of findings, results, and outcome. If disciplinary action needs taken, it should be done with HR or the, and the other appropriate departments. there may be policies and procedures that are outdated or need updated. And then there may be an audit that follows any investigation to demonstrate compliance after the issue's been fixed. So there's these things called corporate integrity agreements. And so if you're found to not be in compliance, either the federal government or the state of Wyoming can put your hospital under a corporate integrity agreement. And that agreement makes you have all of these things in place by contract. And then you have to pay an independent organization after you've remedied all the issues and gone through at least 2, sometimes 3 years of compliance and reporting to the governmental entity. You have to pay an outside organization a large chunk of money to run a statistical analysis of how you did after the fact. And so all of that is very time consuming and expensive. And so it's much better to have all of this in place voluntarily than to have to put it in place because you're under a requirement to do so. And then again, I cannot stress enough, it's important that your people are educated on the hotline, the importance of the hotline, and review the training annually.
Allison, can I ask a question really quickly?
Sure.
So I'm assuming all of these compliance things are not new this year,
Right.
right? And so how would you say we're doing as of now? Are we, what grade would you give us?
So I'm not an expert in this, and usually what I end up dealing with is the aftermath of problems if they're not set up properly. As I had said, I think Kim's done a really great job with the resources she has been given. It's an ongoing process, though, to ensure that all of your staff, your leadership, which is your board, your executive team, are on board with supporting your compliance program, giving it the resources needed. So I think you have work to do. And that's okay if you've identified that you have work to do and we start getting to work on it.
Yeah, because I'm guessing you've probably done this before with the board, or no, we've never done this before.
At least
Yeah,
not-
I have not done this training for your board. So I joke that I'm outhouse counsel, and so I come in and provide the resources that are asked of me. And this was the first time that I'd been asked to provide compliance guidance.
Okay, thank you. That
And
helps me
yeah.
have context for what we're talking about. Thanks.
Yeah, and since all of you went through the board, the board training that we did back in March, I thought it'd be helpful to provide a little different perspective, especially with all of the changes that we have going on, and also to recognize the work that Kim's doing and help support her in that. So
I have a question. As far as the compliance hotline, is that an in-house number?
It can be an in-house number, or, so it rings to my phone.
Okay.
But it is a separate line, I guess, but I manage it. So you can pick the phone up in-house and dial 725, or you can dial 746-73 or 3725, something
So
like
you're the
that.
one that you get the complaint?
Yeah.
Okay.
and there are other facilities that pay for that to be provided, to a third-party vendor. And then the compliance officer would get a written report. I don't know if I could recommend one or over the other. There's more feeling of anonymity if you have the third-party provider. I don't know if they care as much about resolving the issues in the organization. So, but there are options out there.
Darren's recommendation was to do a third party, and then to even add a ethics hotline within that, so people can report like HR issues like workplace bullying or sexual harassment, things like that too, on top of.
So are most complaints through the hotline, or? do you-
I've not got a single complaint through the hotline since I worked here.
Okay.
And I
Should
think
that be
part of that may
concerning?
be how small the community is and the hospital size.
Well, but I mean,
Yeah.
if we haven't had any.
So
really-
I get a lot of my anonymous complaints or whatever
Yeah.
through action queue, because you can put it into
Oh.
anonymous action
okay.
queue.
So
That's how
you-
I get my
yeah, okay.
anonymous.
Do you know about this hotline?
Was
Do
that?
you think staff knows? I mean, because it says education, do you think they know about the hotline?
They do know about it,
I'm guessing they
probably.
just use action queue if they, cause you can be anonymous
It
there.
doesn't feel anonymous.
I
And
think
they know that
people-
Kim's
yeah.
answering. They know, she knows who they are.
That I could probably recognize their voice.
Type.
Yeah, action queue is one of their, yes, they would be typing in their complaint and then it would get submitted anonymously. And yes, I think
Yeah. that would
in
be
a
the
town
best
that's
way
as,
to do it.
in a facility that's as small as this one, that's probably why people would use that more, cause then they feel like it really would be.
And we have a report of concern form as well that's on the Everyone Drive, and it's a Word document, and I tell everybody that you can get in and edit it through Word, so you can type in it, so you don't even have to use your own handwriting.
Oh, sure.
If people are concerned that their handwriting could be identified as well. But I try to educate people that I don't even care whose name it is, I just care about the situation, so.
If they call you on the hotline, is that recorded?
I don't know, I don't believe so.
Okay.
Usually they're not.
And I understand the privacy issue, but also I understand, okay, you didn't handle my problem.
Yeah.
So that's the thing about being anonymous. If you don't give enough information, it's kind of a disservice to both of us. I don't have enough information to solve your problem.
And you
But
don't.
And
then,
you can't-
and we're both frustrated because you feel like your problem's not been taken care of, but I'm frustrated because I don't have enough
Know how to do
information
it.
to take care of the
Or
problem.
you can't
Or
even
who
go
to
back.
go to take care of the
Right.
problem. So
Right.
there's some frustration on both sides because you felt like I've just ignored your problem.
Yeah,
Right.
so they finally come frustrated enough, they come to you and say, well, I left you a message.
The new store. This is the one-stop shop. We have a pharmacy. We have a bootlegger's liquor. The deli, the food that you can get at a lunchtime is so amazing. The coffee shop. Certain Friday mornings, there's 30 people sitting here in all these chairs. This is the hub for people to come and visit, have their coffee, have their donuts. It's amazing what this area has done. Totally amazing.
Yeah,
Right.
so they finally come frustrated enough, they come to you and say, well, I left you a message. This is the message you left.
Yeah.
And they didn't realize that, oh, I forgot to tell you this part of the story. They're so excited, so,
Or nervous or
eh,
anxious.
angry, whatever.
So when I do orientation for new hires, I do tell them that piece, like, if you're gonna do something anonymous, that's completely fine, but please give as much detail as you can, because unless you come tell me, hey, that was me, I don't know who to go to for further information.
They answered the question that they didn't answer.
Yeah, and then I use that same example. You're frustrated, I'm frustrated because I can't help you, but you feel like I'm brushing you off. So
Yeah.
Great conversation.
So the first step in having a functioning compliance program seems to be the mechanism by which someone could report a potential problem.
Yeah, that's
Right.
one of the components. The other is to make sure that you have a policy in place that recognizes the compliance requirements and
Right.
ensures that the entire organization is informed of them and that they agree to comply with them when they sign on.
Do we have those compliance policies here?
we do.
Okay.
So part of my thing with Darren is reviewing all of those compliance policies and making sure that they're easy to read.
Okay.
Instead to make them like 8th grade level reading, just so that they're easily understandable. So going through and reviewing all of them, that's gonna be a task that you have.
Yeah. You have 1,254.
I don't personally,
Compliance
no,
policy?
all
Oh,
together, but going through them and making sure, because part of that is to review all the policies, and if there's a compliance one that maybe is hanging out at the manor or something, bringing it back to compliance. So I have to review all of the policies to make sure and then bring them back to me. So that's a task in and of itself.
All
one
the
a
fun.
day for the next 5 years of your life.
Yeah. So then this just covers the compliance concern process that we talked about, but it's basically there's an investigation review against the rules and procedures, potentially involve legal counsel, provide a written report, and then report it out to the committee. So when we're talking about components of compliance, there's the audit piece, which is we're looking to see if there are problems and trying to fix them as we go. The compliance piece, which is promoting the prevention, detection, and resolution for anything that's not complying with the law. And then the legal piece to make sure that we're advising our organization on the legal and regulatory risks and trying to help manage those risks to avoid legal action, and then if we have it, to try and resolve it through legal action. We also bring in human resources to make sure that we're getting the right people on board to support our compliance program, because if we're employing people who don't care, it's pretty hard to have a compliant organization. Then we need to make sure we're educating those folks. They serve as the front line, that we're training and assessing understanding and compliance. So a lot of organizations subscribe to online software that they have their compliance training already canned and provided, and your people go through and do the training annually to make sure that they're up to date, that they have a passing score on the quiz, and appear to understand the compliance issues. Do you guys have something like that, Kim?
We do, we have it offered through HealthStream and it's annual.
And do you find it to be effective?
I do, yeah. Yeah, it touches the main components of compliance, yeah.
And then the last piece is the quality improvement. So making sure that we have consistent, safe, and high quality practices to help us improve our outcomes and minimize risk of harm for patients. So policies that you may want to have include the list here, code of conduct, and maybe this is helpful to you, Kim, but corporate compliance program and education, HIPAA compliance, anti-kickback, Stark law, fraud and abuse, non-retaliation, and ineligible persons under federal programs, which I'll go through each of these. So the board responsibilities as to the compliance program, things that you may want to look at is how does management work together to address risk? How are the risks being identified? If they're identified, how are they being investigated? How do groups in our organization communicate about findings? How does management choose what to do if they have a finding? And how does the board receive reports on risk mitigation and compliance? These are some areas and questions that might provide some guidance as you guys continue to build out this program. Conversations that you may want to keep having. Anything you want to address on there, Kim?
No?
And then how is management accountable to the compliance program? Do we have a scorecard or some other way that we're measuring how we're doing? Are we mitigating the risks, implementing corrective action plans? Are we giving reports on the investigations, audits, hotline call activity? If there's fraud or senior management misconduct, or is the board hearing about it? I don't personally know of any that's not been reported to the board, just so you all know. And then updates on significant regulatory changes and enforcement events. So like if OIG is really going, that's a federal government program. If they're really going after a certain area of compliance, are we looking at that area of compliance and how are we doing in that area? And then the compliance officer should report to the board regularly and also when certain criteria are met based under your policies.
So Allison, on what source of information could we reference to know, you just mentioned that we should be aware of where, say, the OIG is certain areas they're focusing on. Kim, maybe you could answer.
They
How-
have an OIG work list.
Oh, okay. So we have access to know.
It's on the OIG
things,
website. They have like their,
Focus areas
Yeah.
and they change them once a year and you can, there's
So
a
we
newsletter
can
that you
find
can
that.
sign up for.
Oh, really?
I get newsletters probably weekly, so.
of all the changes and what to do.
Okay.
And so if something comes up on that list and Kim's like, boy, this kind of might apply to us, that'd be a really great education topic for the board and the organization. So. Okay, so corporate governance, this is the board's responsibility to understand. So what is the scope and adequacy of our compliance program? And we're getting a little into that today. It may make sense after Kim's gone through her work with Darren, if the board chooses to move forward with that, that Kim would come back in 6 months or something and provide a update to the board of the governance of the compliance program, where they're at, what they're doing. What are high risk areas that they've identified for compliance and what are they doing about that? How do they plan to stay updated on changes to the law? What training or tools does the board need to effectively oversee the compliance and program and govern? And how and when does the board receive information about compliance concerns or changes? So again, a lot of this is questions, but it's to help the board start to think about what is our role? What do we want it to look like? How do we want to be informed? What information do we need from Kim or the compliance committee once it's formed to help us understand what they're doing and where they're at? What education do we think we need? So let's talk about some compliance risks that we're familiar with in the healthcare industry. So one of the major ones is whether you're submitting accurate claims or not, which sounds really easy, but it's very complicated, and we'll talk about that. The referral laws, which are Stark and Anti-Kickback, EMTALA, which is the Emergency Medical Treatment and Labor Act, Substandard Care, and then HIPAA, the Health Insurance Portability and Accountability Act. So let's start with claims. This is the single biggest risk for hospitals. In order for a claim to be accurate, it has to actually be accurate for the services that were provided to the patient that it was provided on the right date for the right amount of time, if that's relevant. The documentation has to be complete, and that's set by the federal government for Medicaid, Medicare patients, and then by the third party like Blue Cross Blue Shield for others. That needs to reflect reasonable and necessary services that are ordered by an appropriately licensed medical professional, and documentation needs to be provided to support the claim. So each one of those areas is an area that you could mess up on, and I've seen it. Like, for example, we had a provider who provided a service that they weren't technically licensed for when they did it, but they later got licensed, and that was caught in an audit that was done. And then if you find that you have received more payment for the services than you're entitled to, you have a duty to disclose that you were overpaid and return those overpayments for the mistaken claims. If you submit claims, requests for payment to the federal government that don't meet that top paragraph, then they're considered false claims. False, fraudulent, or misleading, and it's illegal, and it can be a criminal action, although a lot of the cases that happen with the hospitals we work with, unless it's nefarious, usually it's just fines associated with it, not criminal time or penalties. So
is this accurate claim requirement just for the government or for all insurances and anybody that we would bill for something?
Yeah, so with the federal government, you're subject to all of their laws, which make it a much bigger deal, though you contractually have an obligation to whatever your contract says, for example, with Blue Cross Blue Shield. But I haven't looked at them, and Carrie may know more than me on that point, but it's similar.
Carrie, are we using, because Sandy told us that we submit claims to the SSI clearinghouse. So are they helping us with the complete part? No.
No, you have to do chart audits to that's part of what you do to make sure you're submitting accurate claims and monitor your claims process and stuff. Your clearinghouse is just a person in between. They just are fed the information you feed them. So you're
So how do you think, if you don't mind me putting you on the spot, how do you think we're doing on the whole with the accurate claims requirement?
Without a chart audit, I couldn't answer that question for you.
Okay.
And I don't know if we've
As
been
our
doing
audit.
them.
I do, but I don't know that I do.
That you match the claim to the
Yeah,
chart audit.
Yeah. And that was one thing that I talked to Darren about. I said, how much information on this should I know? Like, should I know like coding and all of this? And he goes, yeah, you should know coding. And I said, well, I'm unfamiliar with coding for the most part because there's so much that comes with coding. And so he said, yeah, you should probably know some coding and things like that. But he said typically a lot of that can be done with third-party auditing professional systems.
So we started the conversation, and Allison, the one thing I really latched onto that you said is it's the board's responsibility to make sure we have a functioning compliance system. So I guess I could have done a better job of my question. And maybe no, I don't know. I have no way of knowing. Does anybody in the room have an opinion on whether we have a functioning, accurate claims compliance process? Do we?
So Allison, I'm sure. could
Yeah,
speak to-
so this is an area that can be very complicated, and I think the only way that I could answer that is if we had an independent party come in and do an audit.
Okay.
And they will do those spot checks in different areas of your organization. And I would recommend that be done. And maybe Darren has some contacts. I know you guys have a lot on your plate. And so I think you got to make the triage list and just start walking through it a bit at a time. So
I could see this being part of our redesigned
Right.
compliance process, so.
yeah, I agree. And I will tell you, in my experience, if you do an audit, you will find claims that need fixed. Hospitals are large, complex organizations, even your size, and the claims process is complex. And training on documentation to support claims is a good idea to do annually. So.
I'm not tooting my own horn because I'm pretty awesome at this, but you will still find stuff in my charts
Yeah,
because it's complex. I mean, that
And
doesn't mean
so-
we're out of compliance. It just means that's why we have a compliance program. So,
Yeah. So for the organization that was under the corporate integrity agreement, on the review of the claims by the third party that we had to pay so much money for, we had to get at least a 95% accuracy rate, which is actually a pretty high accuracy rate on claims. So. That enough on that topic?
Yeah. Yes, thank you.
So then on the accurate claims piece, the most common coding concerns have to do with outpatient procedure coding. So the coding modifiers were changed, and again, Carrie's probably more experienced at this than me. But a lot of the facilities didn't update their coding, and so there's a bunch of modifiers in there that are incorrect, and it can lead to overpayment. So you have to make sure that since that change occurred that you've updated your process. And then charge masters, those also need to be updated. And evaluation and management services have to be medically necessary and sufficiently documented. There are issues with admission and discharge, so making sure that you're not charging too much if somebody comes back to your hospital. There's issues specific to mental health. And like I said, same day and then readmission of patients. There's supplemental payment considerations. So these are areas that they have coding concerns with, cardiac rehab, educational activities, billing for those sorts of things. And then use of information technology made billing and coding much more data intensive. And so you have to have a much more robust system to accommodate the coding adjustments.
Allison, will we be able
Yeah.
to have a copy of this
Sure.
slide deck?
Yep. Happy
So I
to.
don't have to write everything down.
Yep. And I also, again, would recommend the document that I sent out. It's much more robust. But I would use it as a reference tool to help answer questions if I don't
Okay.
address them today.
Okay.
So then we'll get into the referral statutes. The first one is the physician self-referral statute, known as Stark. It prohibits hospitals from submitting claims for services that were referred to the hospital by a non-employed physician with whom the hospital has a prohibited financial relationship. Financial relationships can be leases, like leasing that non-employed physician space, gifts, exchange of personal services, all sorts of things. There are exceptions outlined in the law. Usually what you need to do is look at what the fair market value of the services are and make sure that it meets that guideline. When you're looking at physician recruitment compensation benefits, you have to make sure that you're not exceeding fair market value. And then the best practice is to review contracting and leasing processes to ensure that we're not overstepping this. I'm not an expert at Stark. There are attorneys who just do Stark law. It also can get very complicated. My partner Tom jokes that basically you just can't pay doctors anything and then you're safe. So I don't think the doctors like that. The doctors want to be paid everything, but probably the truth is somewhere in the middle. So then there's the anti-kickback statute. It's a criminal statute and it prohibits the healthcare industry from offering or accepting gifts or payment to reward for past or potential future referrals. It's a violation if only one purpose of the remuneration or payment is to induce or reward the referral or recommendation. There are safe harbors such as fair market value. And the problem areas we see for this are joint ventures, physician compensation, relationship with other healthcare entities, recruitment, discounts, credentialing, and malpractice insurance subsidies. You'll notice in any agreements with Monument that it talks about it being an exchange for fair market value. It's because it's a relationship with another healthcare entity. So then we'll talk about EMTALA, which is one of my favorites. The federal law says that you need to evaluate and stabilize every patient that comes through your door without regard to their ability to pay. Oh, and I need to update this. Sorry, I still have CCH in this slide. I'll fix it. So when an individual presents at your hospital and is suffering from an emergency medical condition, you have to screen them, give a screening exam, make sure that they're okay. And if they're not okay, you need to provide stabilizing treatment. After you've provided that stabilizing treatment, then you're able to ask about their ability to pay or insurance. I don't know if you guys have a policy or procedure in place on this, but there are issues that arise from EMTALA quite regularly.
Right. I have a question. So I was reading some articles in the news recently. Now that there's states, and I'm not sure where Wyoming's at with the whole prohibiting abortions and things like that. But it's basically, I think maybe there's a court case in Idaho or something where if a pregnant person would come into the emergency room and would have to have an abortion to be stabilized, that could put the hospital in kind of a tricky situation. You mentioned this as kind of a favorite topic. Do
I
you
don't know, is your facility
that's-
even capable of doing that?
I don't think we are. And so
don't
I
think
thought
you are.
initially that it would be a non-issue for us.
I think that patient would probably be transferred, which would get to the last point on this.
Right.
And usually you guys are in the transfer bucket. So my larger facilities have to make sure that they are accepting requests for transfer of patients if they are capable to treat and have the capacity to take that patient in. And then there's some really specific rules about when you're asking for a transfer under EMTALA, you have to make sure that you're providing the necessary medical information on the patient so that the facility you're requesting to transfer them to can see if they have the capability and capacity. And then you have to cooperate with making the plans for the transfer.
So Kim, did you recently complete EMTALA training?
Mhm.
Yeah, okay.
Good.
So are you kind of the point of contact?
Yes, so, Deb and I have done EMTALA training. Holland and Hart also provided EMTALA training that we invited all of the medical providers and, hospital staff to. It was like a lunch and learn.
So did quite a few people come?
Mhm. So there's just been a lot of education just facility wide on EMTALA.
So if one of the ED providers is a little unclear on can I transfer, I assume they know these things well, but if they had questions, they would call you or call Deb
They
or?
call me. Yep.
Okay,
And then if I still have questions, I can get a hold of, either Allison or risk management
oh, okay.
too.
And
to say-
who's risk management?
It's our Yellowstone. I
Oh,
have a
Yellowstone.
contract with them and I can say, here's my situation or perceived situation that could happen. What is our responsibility, risk with this? So.
So you're going to the Yellowstone training
Mhm.
later in the month. And so they do malpractice stuff, but also risk management.
Yes.
Okay.
Yes. Yep. So they do a lot of risk management to prevent malpractice.
Sure.
Yep. And so one of the things that we do at the Yellowstone is we go through claims that have happened. And so
Oh,
it's a good educational what not to do.
So your organization is much more likely to be an EMTALA reporter on someone who your facility feels like was denied a transfer request. Although it's probably worthwhile to go through your intake procedures to ensure that you're doing the analysis and stabilization before asking about payment. Any other questions on EMTALA?
no, I'm good, thanks.
Yep. So then we'll talk about substandard care. So this is if you're providing care that's either unnecessary or doesn't meet the standard, can result in an exclusion from participating in federal healthcare programs, which would be a really bad deal. This is more common in large cities where hospitals have just fallen well below the standard of care. But it is important to continue your quality program and demonstrate that you're meeting quality through goals and measuring performance. And you have to comply with the Medicare conditions of participation. And this includes proper oversight of credentialing and peer review of medical staff. I do think an area that we could improve is the functionality and purpose of the medical staff. And so that's something that I would recommend maybe the board chair or someone meet with medical staff and start that conversation. I don't know how much training and guidance they've had on medical staff issues over the years. In most of the facilities we work with, we're not the counsel for the medical staff. There's usually another attorney who does that work. So just some ideas. And then we'll talk about HIPAA. So the way I like to think about HIPAA is like what happens at your facility stays at your facility. So HIPAA gives patients control of their healthcare information and makes it illegal to release health information to inappropriate parties or to fail to protect it. It protects any information that can be used to identify a patient, including their name, date of birth, social security number, phone number, address, etc. And employees can only share the minimum protected health information that's necessary for them to do their job. So as you can see, there's a lot of gray area in interpreting HIPAA, but it's important to make sure our employees are being trained. They only access the protected health information if they have to have it in order to carry out their job. In a facility like yours, it's important to not discuss HIPAA protected information in open areas, to not leave documents in printers or fax machines unattended, and to not leave a computer unlocked that has access to protected health information. If any protected health information is in a print form, it should be shredded once complete, and there should be an audit system in place regarding your HIPAA compliance.
What's that look like, Allison, an audit system? that you've seen?
Yeah, so for example, we've been working with Kim through Darren and Monument to get automatic reports that show sort of like out of the ordinary access to healthcare information.
When governments pay us to get the word out, governments pay us, but we actually work for the public. And so it's a tough spot we're in because we have to piss off our own clients, basically. The people who sign the checks we get in fights with because we're fighting for the public. And I don't know. All I can do is say that we just got to keep doing what we do and hope that governments, especially in election year, governments need to trust the professionals, and we are the professionals in Weston County, to get their message out.
Exactly. I can't think of anybody else that does a better job. We put a lot of time and effort into getting all of the product out there and making sure that we reach people in as many avenues as possible. I don't think people understand how much time and effort that we put into those things. And it's most definitely more time and effort than we get compensated for.
Yeah, so for example, we've been working with Kim through Darren and Monument to get automatic reports that show sort of like out of the ordinary access to healthcare information. And that was put in place a couple weeks ago now, Kim, a week?
Yeah, I think it was last week, maybe. The days are running together. I think it was
So
last week.
that's one example is like, oh, hey, here's a red flag report, basically. And then that way the data is coming to Kim rather than Kim having to go try and spot check it randomly. When you're looking at like all of the information that's going through a system, even for the size of your hospital, it's impossible for her to be able to get anywhere trying to just spot check that data. But additionally, Darren may have some other ideas. There are consultants who can come in and do HIPAA audits. There's also, let's see, I think it's on my next slide. There's also the security rule, which is looking at the IT side of HIPAA compliance. And so this talks about safeguards. The bottom is it reasonable? Are the safeguards reasonable? What are the physical controls? So like, are areas where healthcare information is being accessed separated off from the public? The printer is in a place that it's not in a public area. And then there's also the technical safeguards of like, do we have proper IT controls in place to ensure that our data is protected? And so this is, if you're in a corporate integrity agreement, this is how they're looking at the safeguards for the protected information. And then these are the areas that they're looking at as identifiers for protected health information. So these are the things we need to protect.
I do have a question. Sometimes when I worked in the emergency room in Gillette, if we were really busy and I had 4 patients or whatever, and a doctor gave a new order for a med, and one of the nurses that I was working for said, I can give that med for you because there's a new order. Does she have the right to go into that chart and look at what's going on with that patient? Or can she just look at what drug allergies that patient has before she can give that med?
Yeah, so that gets back to the basics of making sure that they can only access the minimum necessary to do their job.
So, okay.
So
So
Allison,
if she only needs the allergy information, then that's what she should be getting. If she
Okay.
needed in there to understand weight or other medications or something like that, then it would be appropriate.
So she shouldn't be looking at lab values if it's not based on, if it's not based on the specific med you're giving.
Right. Yeah.
I
so,
just always had a question about that. Thank you.
so Allison, there's all this 18 identifiers of HIPAA. If somebody somehow hacked our network and HIPAA information got out in the open as a result of a hack,
Yeah.
how serious of a problem would that be for us?
Yeah, so with the organizations that I've had where something similar-ish happened, in the case I had, it was a spreadsheet with protected information that went out to wrong party.
Yeah.
We ended up through our insurance, we ended up hiring a law firm who specializes in HIPAA breach compliance. And we were required to get notifications out to all of them. If it's large enough, I think it's 500 patients that are affected, then you have to publish it in the newspaper and all sorts of other things. So it can be very expensive. And then they also can sue you for any damages they have associated with that information getting out.
And would that potentially bring about a confidentiality or a, I'm sorry, what's the term you've been using all evening about?
Compliance?
Yeah, compliance, yes.
Yeah,
Agreement.
so then usually the federal government will come back and audit you and fine you in addition to all the expense you have to go to for the compliance issues. And then if there's a specific individual that's associated with a HIPAA breach, you know, I think you've had some training on this, but they'll look at the history of that employee, whether they've had historic HIPAA breaches, what training they've had, and determine whether any employment action you've taken is appropriately tailored to the incident. So,
Thank you.
yep. So then I just have some examples that I felt like might illustrate some of these issues. You know, this comes off of the OIG website in a lot of cases. So the federal government likes to report when they fine people because they feel like that's a deterrent. So this is an example where anesthesia provider was basically getting kickbacks. And so they had to pay more than $28 million to resolve their kickback and false claims allegations with the federal government. And then what happens is there are people maybe within your organization or Joe Public who are familiar with this going on or notice that it's going on. And there are these laws called key tam laws that allow them, they're called the relators. If they report it and they bring the case, then they get a portion of the proceeds. They get their money too. So the relators in this case got $4.7 million out of the settlement. So this is a Wyoming case. It's a fraud case. There was a Wyoming resident out of Cheyenne that was sentenced to a prison term for defrauding the Wyoming Medicaid department. The repayment in that case was smaller. It was only $58,000 plus restitution to the Wyoming Department of Family Services. So there were false bills to Medicaid filed between 2013 to 2016.
Was this person a provider?
Yes. Yes, it was a provider. And it's notable because it occurred in Wyoming. We don't have a lot of cases in Wyoming, but Travis Kirchiefer, who you'll see on there with the Wyoming Medicaid Fraud Control Unit, is the attorney that I worked with on the corporate integrity agreement that I had worked on previously. So. And then here was another one. A Wyoming psychologist was sentenced to 3 years of prison for health fraud, for falsely billing Medicaid, and was ordered to pay $2.28 million in restitution. He claimed to be a treating provider, even though most of his services were provided by unenrolled, often unlicensed people who could not provide mental health services. So like he was having unlicensed people provide the services and then he was billing. You can read the rest of it here. Pretty crazy though. And so as a board, the idea is like you need to be able to tell if there's something fishy going on, right? So the federal government's now starting to have systems in place where their computers will pick up anomalies in certain billing areas. And if something looks weird, then they may go in and audit your organization. So for example, if this psychologist was associated with your facility, they might pick up that there was like a whole lot of billing going on that didn't really make sense for the size of your organization. Then they might come in on their own and decide to audit. So just because a billing center looks like a really good deal for your organization, you need to make sure that it actually makes sense on paper. And then here's another example out of Texas. This guy was sentenced to 10 years in prison in order to pay back 6.2 million in restitution for an anti-kickback statute and conspiracy to commit healthcare fraud. So they orchestrated a scheme where they paid illegal bribes and kickbacks to group homeowners and patient recruiters in exchange for sending Medicare patients to them. They knew that the patients did not qualify for and were never provided legitimate hospital services. So. And then an ineligible person means somebody who's been put on the federal government's list saying these people are not qualified to provide services. And usually I think it's because they have been found to have done something that violated law, although that's again not an area that I specialize in. But this hospital agreed to pay $88,000 for violating the civil monetary penalty law. The hospital employed an individual they knew or should have known was excluded from participating. So basically, if the person is on the excluded list, they can't bill. And I'm pretty sure your facility has in place a search of what providers are excluded. Kim, do you know?
We do, yeah. So
Yeah.
what part of the credentialing process is that with the providers and then do that monthly? And then I believe HR, part of their portion that they're gonna start doing is all of the other employees monthly. Because you can't even employ like a nurse. Because
Right.
we can bill for services for the nurse. So if you have a nurse that's on the exclusion list, we can't have them working because we can bill for their services.
Do you check them yearly?
So that's supposed to be something that I think Charlotte's gonna start doing monthly, just because some people are naughty and.
Well, I check mine yearly as part of when I do my checklist, my compliance checklist. I do them all yearly.
I do the providers monthly, but. Yes, but, you know, I don't want us to get in trouble by, especially where we have like the neurology group and stuff. I don't know. Usually those,
But you don't bill. We
No.
don't bill for that.
no, but I still just make it a habit. Good.
So then this is another attempt at humor. But you know, I think looking forward, the board needs to see like, what do you think the strategies are for you for oversight? What do you want it to look like? And as Homer Simpson would say, number 1, cover for me. Number 2, oh, good idea, boss. And number 3, it was like that when I got here. And then maybe some tools for oversight, like what do you need to get the job done? And I thought this was pretty funny. Mr. President, you have a package from the new House Democrats. You know, but it's education. It's having the compliance officer feel comfortable in her job and reporting to the board, updating the policies, getting the support to have the right auditing processes in place. So it's kind of all of this stuff. When you talk about what is the compliance program, it's all of this. So that's my presentation.
Thank you, Allison.
Thank you.
Yeah, and I don't know if anybody wants to discuss more, you know, concerns or things that we brought up, but that's the overview I wanted to give you. And there are lots more materials out there if a certain area piques your interest. And as I said, that handout, it has a whole lot of information in it. So
What, What is our responsibility with the Title 25 patient?
Title 25? Do you Title 25 patients?
No, haven't in the past. Did it one time. But
We
So
do.
you-
Yes, we do all the time.
well, I mean, do we house Title
We
25?
don't house them. We,
No, one time there was a room that they housed Title 25.
Yep, so the county attorney is the one that's supposed to provide the legal services as to whether or not they qualify, and your providers, to the extent they're qualified, are able to evaluate whether the person is a harm to themselves or others. The county attorney is the one that's supposed to provide the legal services as to whether or not they qualify, and your providers, to the extent they're qualified, are able to evaluate whether the person is a harm to themselves or others. The police can also do that, or sheriff, as may be the case. And then there's a rule that's like 72 hours. They have to have a updated analysis and determination of whether they'll continue to be held for a hearing. Title 25 is something that's unique, and it kind of overlaps with EMTALA a little bit, right? Because sometimes those people are an EMTALA case. The federal government doesn't worry about Title 25, though. That's a creation of state law. And so when you ask what your obligation is, hospitals are not required to take a patient that they are unable to take care of.
Right.
But you are required under EMTALA to evaluate and stabilize. And so you need to get that part accomplished if they come to you for services. And then from there, you need to find them an alternative placement because you're not qualified.
So Allison, can I ask a question? So when Shannon worked at Torrington and then here, most of the Title 25 people, I think, would go to Casper. But there's always been kind of a gray area where I've been told that if a person's Title 25, they legally become the responsibility of law enforcement at that point, but that, and I don't know if it's still this way, but I just have a very fuzzy recollection that sometime that we have a difficult time getting the person to the place they need to go. And what can we do? As the last I heard about it, the sheriff's office says they don't have enough people or manpower to do that, and most ambulance services don't want to take
So
them.
we have a contract with Don Taylor.
Oh,
So
okay.
he will transport our Title 25s to wherever we find placement.
Oh, okay.
And then he just builds
Oh,
the
okay,
city
great.
for his transportation.
Oh, okay,
So yeah.
county.
great.
But
Yeah,
finding a
makes
place to put him, that's the trick.
Yeah.
It can be very hard. So Campbell County fills up. The state hospital is perpetually full, has like a 2 to 3 month waiting period. I mean, not to be alarmist, but we have a mental health crisis in our state. It's not unique. Most states are suffering from these issues. And it is a
transfer to
frustration.
Rapid here or not because it's across the state line.
The county is the one that's supposed to pay for the services under Title 25. And so it's up to them. I think I don't know if you have a contract with the county or not, so I don't want to speak out of turn.
We'd send them to Rapids and Gillette.
But,
Take them.
but as far as EMTALA goes, EMTALA is a federal law, and so you can request transfer anywhere. And if they have the capacity and the capability, they have to take them.
They can't refuse them because they would, a Wyoming resident going to Rapid City or something.
That's right.
I think I had to transfer clear to Billings at one point, just.
Have you,
if I'm trying to recollect, you know, because that was the only accepting.
Way back when we used Casper a lot, and there was Rollins at one time that we had to transfer
The
to.
majority of ours go to Wyoming Behavioral, WBI.
In Casper. Right?
Yes, but sometimes we find them to be at capacity, and so you'll see sometimes, in quality, we talk about transfer times. You'll see like a really bad outlier patient that was in the ER for 19, 20 plus hours because they were a mental health patient, trying to find them placement. Yeah.
And we talk about that a lot in the ethics committee too, these Title 25.
Well, I've always been very worried about the staff and their safety. If we get somebody that's really wonky and out of control.
So the jail, if, you know, the police or sheriff are also qualified to take people under Title 25 and hold them.
Right. Yeah, but my understanding is they typically will not because they don't have enough people, and that leaves our staff with the potentially difficult situation to deal with.
It's probably more likely that they could take him to the jail. It's these long transfer times,
Oh.
so troublesome.
So if they feel like they can't handle it, what are they doing? What?
At one time, the jail had a padded cell in it. The padded cell got destroyed many years ago, so now putting a Title 25 in a jail where they could hurt themselves, harm themselves. At one time, the county put officers at the door of the room, but also that took 24-hour guard for that room.
Same trouble.
With the same trouble as
That
transfer.
happened to me in Gillette, though. We had the patient in the hospital and the officer with the patient.
Yeah, but Gillette used to take some patients on the 5th floor at one time in Gillette, but since then, I don't know that.
They're usually full.
Yeah.
Yeah.
So Kim, you mentioned Don Taylor, the city pays Don Taylor?
County.
Oh, the county
Yeah.
pays.
So we
Okay.
just call him up, say we've got a transfer.
He just puts them in his car or something?
He's got a van.
Does he tie them up? Does he let them
He does.
run loose in there? We don't know what he
I don't
does.
know what he does.
Oh,
It's not just him alone.
Yeah, he takes a.
And I think he only would take a person who's not requiring being tied
Well,
up.
there are patients that would be required to be strapped down, but there's also juvenile patients.
well, but can an individual tie somebody up and take them? I don't know.
No,
Probably not.
No, I don't think
I
so.
think maybe you could.
Me?
As a private citizen, maybe,
Like,
but as a healthcare worker, you'd be in big.
Yeah, yeah.
That was part of our issue with the EMS crew is they can't take sedated patients. So
Right.
if we had
Oh,
a
you said-
very,
Right.
Abusive patient, we
Can-
had to sedate them.
Can't they sedate patients? So they can't
That
take a
was the
sedated
issue
patient,
that
but
was-
they can
Yeah. that they
sedate a
can't-
patient en route?
They can't
No.
take a mental health sedated patient.
Really
Because
interesting.
I guess in their eyes, they're not technically stable. And if they wake up in the back of the ambulance,
they'll jump out.
being
or the
arrested,
trunk of the Impala.
it's safety for them
Okay.
too. So
Right,
Right.
I mean,
to run into,
Yeah.
it's the ethical portion
sure.
of it.
Yeah, I used to drive the ambulance in Torrington as a volunteer because we couldn't get patients transferred from the Torrington hospital. We had all the EMTs, but there was nobody driving ambulance. I thought, well, that's a silly problem. I can drive. So they would call me and I would do it when I could. But they told me they used to take Title 25s and then they had one jump out at a stop sign or something, they stopped and they just, took off. And they said, we won't do it anymore.
Transport them
So it's
anymore.
kind of a problem
It is
everywhere. And anyway, okay.
All right, we're back to you, Allison, I think.
You're good. That's all I had. So, I just think this has been a great discussion. I would recommend making, Kim advocating for a change to the org chart to have a line to the board. And then, tomorrow night we'll have some more discussions that are tangent to this, on the compliance piece. Other than that, I would recommend that you have some updates from Kim on how things are going, what she needs from you, and what she would like to see going forward. So,
Yeah, I do have one last question, Allison. It's more of a broad question, but I've heard it several times. So talking about maybe changing the org chart for Kim and all of that. Is there a line where the board is not supposed to get itself involved in operations of the hospital? Is that?
yeah,
Where does-
so from a good governance standpoint, and there's lots of materials out there on board governance, but from a good governance standpoint, the board should only manage the CEO of the organization. That's their only employee. However, in healthcare, there is an exception for the compliance officer. It's not that you're managing the compliance officer, but you need to have a reporting relationship with the compliance officer to ensure that you are hearing any concerns he or she has on compliance and that you are giving directives on what needs to be done related to compliance.
Okay, so we could legitimately change the org chart if we wanted to for Kim to report to us,
You should.
and that wouldn't be any violation of
No,
getting
and
in.
I would approach it as we think this is good policy. What do you think, right?
One more question, if I may. Errors and omission insurance for the board members. Do you recommend that? Do we have that, you
Yes.
know?
Yes. Yes.
we do have it, or yes, you do recommend
Yes, you
it.
do have it, unless it's expired, which I doubt. You get it annually. And I do recommend it. Even though you are immune under Wyoming law, it's always possible that there would be a federal action that could be brought that you would not be under the Wyoming statutes for. So.
Oh, that's something, especially us new board
Now,
members.
what did you call it?
Errors
Say it
and
again.
omission insurance?
Oh, insurance.
So is that insurance we need to carry privately?
No, the
No.
music organization
The
buys.
entity should carry it for you.
Okay, do we know if they are?
Well, that's what I was gonna check into.
Yeah, I was just asking those.
It's usually
You're
like
looking at me like
A $500 policy, but as long as you are doing your duties, you would have some coverage. It's when you go outside your duties, you're not covered.
Sure.
And the hospital does have an obligation under Wyoming law to defend you and to pay anything damages wise related to your service as a board member, as long as you're acting within the scope of your duty as a board member. So if you go off and start talking to someone on your own without the support of the board or a vote, that's on you. Any action you take as a board or discussion you have in furtherance of the board work, as you're doing here, is something the board would have to back you up on. I mean, the organization would back you up on. Kim, I don't know if you know about that policy. It'd probably be worth checking to make sure that it's in place and what the coverage amount is.
Is it through the state of Wyoming?
No, usually it's through like Yellowstone or a different provider. It's an insurance
Right.
company that provides it.
Seemed like we were getting in out of Cheyenne. They don't know what company that was. I'll have to think about that.
Those are all great questions, though.
Are there any other questions? Anything else we need to? So, go ahead, Allison.
This might be the shortest board meeting we've had.
We're not done with the ribs.
Thank you, Allison.
Thank you.
Yeah, probably you ought to do a motion to adjourn just so that we make Denise happy.
Okay, so the other thing, but so I want to just give them a kind of an update on homework since we're getting done so early. Should I do that before we adjourn or after we adjourn?
If it's not technically a part of the meeting, I'd adjourn and then you can just give it. It's fine.
Okay.
The doors are open.
Okay.
I make a motion that we adjourn.
I second it.
All in favor, say aye.
Aye.
All opposed, the same. Oh, good job, guys. Okay, so this packet, Let's look at it real fast. There's somebody open it up and then. So in it has some money, like how much different.
Could we maybe stop the recording just so that if it's
yes.
used in the future, it's not?
In addition to the weekly printed version of the newsletter journal, we also promote our community and share important information on our award-winning website, newslj.com, and in our weekly email newsletter, Nuke Now. We also connect with readers through various social media platforms and invite you to check us out on Facebook, Twitter, and Instagram. You can even take a look at a recent meeting of the City Council, School Board, or County Commission on our YouTube channel. We do hope that you will go to newslj.com and subscribe today, and we look forward to making all of our great content available to you. But regardless of your level of support, we thank you from the bottom of our hearts for doing your part to preserve a free and independent local press.